Good morning and welcome. We are required to inform you that this webinar will be recorded and will be made available on our website later today. Attorney Isles will now begin the presentation.
Good morning, Kelly, and thank you very much, everybody, for participating today. While I can't see you all, I want to say I do appreciate you tuning in. Next slide, please. We're going to speak with you today about a number of things. I'm going to start off by talking about the Stark Law blanket waivers that were issued several weeks ago, and then Jason Gregoire is going to take you through some of the privacy rule changes and waivers, a discussion about telehealth changes and other notable developments. In addition, we will try to get to critical access hospitals, physicians' responsibilities, time permitting. In any event, why don't we start? I want to be respectful of your time this morning. Next slide, please. Okay, let's talk about what situation healthcare providers face today as a result of COVID-19. I don't need to tell you the kind of shock to the healthcare system as well as to other parts of our economy that the coronavirus has presented. Obviously, we have disruptions to revenue. We have a tumult in certain cases in making sure that we continue to have patients attend to our practices. And there is a need to respond to this crisis with new regulations and new arrangements. In these arrangements, we require flexibility. The Centers for Medicare and Medicaid Services have recognized this, and in part, they have issued a number of different pronouncements and waivers. I'm going to focus clearly on the waivers to the Stark Law, because the Stark Law, if there's any law out there that's a barrier to the flexibility that providers, hospitals, and physicians in particular need, it is the Stark Law. As you know, in essence, the Stark Law prohibits a physician from making referrals for what are called designated health services to an entity, a hospital or another type of provider, with whom that physician has a financial relationship. Just at its most basic, this means simply that if a doctor refers services to an entity that a physician's lab, a hospital, another kind of healthcare service, if the doctor has any type of financial relationship with that, indirect or direct, that referral and payments for it are illegal. So by its nature, it's a very broad law. The problem is that in this crisis, CMS has recognized that we need to get around what are the very stringent requirements of this law. As you know, because the law is so broad over the years, CMS has promulgated exceptions to this law. And the exceptions are where the devil's in the details, literally. The law is considered a devil because it's got innumerable complexities with it that are too much for this presentation. But just to suffice it to say that in order to create the flexibility to cope with this crisis, CMS has issued waivers to the strict requirements that are built into the exceptions to the law. So what is a blanket waiver? A blanket waiver is essentially an allowance, if you will, to avoid the strict requirements of the law. These blanket waivers were issued in March 30th, and they are effective March 1st of this year, and they continue until the end of the pandemic or until the end of the national emergency. I don't know when that will be. However, with these, a blanket waiver, therefore, is a way for a provider and a physician of any stripe to take advantage of non-compliance with a Stark Law. CMS issued additional guidance on April 21st, and and um, that guidance has been helpful in understanding these waivers, and I'll touch upon them briefly. So I want to talk today about these waivers. In addition, one of the solutions to this crisis relates to the anti-kickback statute. For those of you who work in this area, the anti-kickback statute and the Stark Law are often seen as twins, and providers entering into financial relationships need to comply with both laws. The Stark Law is a strict liability statute. That simply means that if you run afoul of it for any reason at all, mistake, not and lack of knowledge, it doesn't matter, you will run afoul of the law and you can be subject to penalties under Stark. The anti-kickback statute, on the other hand, is a criminal statute that does depend on intent. Nonetheless, the OIG issued a policy statement at the beginning of last month after CMS issued these blanket waivers, which should provide providers some comfort in structuring these arrangements. The OIG said that it will not seek to prosecute arrangements that are based upon the waivers. So that should give us some help as we go forward. All right, next slide, please. Okay, what do these waivers do? In essence, the waivers allow us to skirt the law by permitting claims that don't comply with the strict requirements of the Stark Law to be paid. So if an arrangement that does not comply with Stark is entered into and bills are made to CMS or to Medicare for payment, those payments will now be permitted and will come in. I should say that this only applies to remuneration or payment between an entity and a physician, or a physician organization and an immediate family member. To take advantage of the waivers, however, there's got to be a good faith effort to comply with them, and the financial relationship has to be protected by the waiver itself, and it can only relate to the national emergency, or what are known as COVID-19 purposes. COVID-19 purposes include the diagnosis and treatment of COVID-19, certainly, but they also include securing the services of clinicians and physicians in response to the COVID-19 breakout, and that includes non-COVID related services. So that's rather broad. If you look at purpose number 5, which I just want to jump to, and is before you, that again addresses a medical practice or business interruption due to the COVID-19 outbreak. That is obviously a very broad purpose for which you can enter into a blanket waiver. I should state as well that these waivers are self-implementing. You can enter into an arrangement. You do not have to file anything with anybody, but you can rely on these for purposes of dealing with the pandemic and providing revenue sources to other physicians. Next slide, please. Again, I mentioned that CMS provided guidance on April 21st. This has been helpful. The guidance essentially requires that these financial relationships from the strict and waivers from the strict confines of the Stark Law still require that elements of the Stark Law be followed. So in other words, as we'll discuss, fair market value is essentially waived for purposes of a Stark Law analysis. But other areas of the Stark Law are not waived, such as the most important thing, that any referrals and payment for them not be based on the volume or value of those referrals. In addition, the guidance provided in late April provided general START guidance saying that parties can amend their agreements, they can amend their financial relationships during the pandemic, and that parties, in fact, could get around the strict 1-year period that these types of arrangements need to be in effect by amending those arrangements prior to the expiration of the first year. The Stark Law is quite a technical law, but for those of you who have worked with these arrangements, you certainly know that the requirements of these laws say that if you amend it, you can't enter into the contract or agreement until the end of the first anniversary. You can't redo, rather, the contract or agreement until the end of the first anniversary of the agreement itself. The other guidance is that they don't apply to indirect compensation arrangements. All of these waivers that have been provided, and there have been 18 of them, 11 of them have to do with compensation arrangements, direct compensation arrangements. The other 7 have to do with the other areas that I won't get into today because I don't think they're really as applicable to New Hampshire practices as the compensation arrangements. Those are the ones that those arrangements are waived. The direct compensation fair market value arrangements. Indirect compensation arrangements may not be changed as a result of the waivers. And CMS did say in its guidance it would work with the Department of Justice to, in essence, assist providers with getting out from under a potential whistleblower key tam action that normally would be brought in violation of Stark. All right, would you please go to the next slide? Okay, so let's just talk about these blanket waivers. As I mentioned, there are 18 of them. I'm going to speak to the principal ones. And as I mentioned, these have to do with fair market value, or the fact that under these waivers, the Stark Law exceptions generally require that there be a fair market value remuneration from one party to the other. During the crisis, CMS has said that arrangements can exist where there is not fair market value. Let me give you an example. Moonlighting. Moonlighting is something that during the pandemic, hospitals may require outside physicians to come in and provide other services. Those physicians may not normally do that type of work. The hospital can provide additional compensation over and above fair market value for that particular service. Another example might be the use of a facility by a hospital that is not owned by the hospital, but is owned by physicians. For instance, the governor issued an order saying that procedures could be done and paid for by insurance companies in a variety of different settings, alternative care settings. Under this arrangement, under the waived prohibitions, a hospital could do that. And if the parties wanted to, they could perhaps pay more for the use of the facility by the hospital's physicians than would be considered fair market value. Other examples might be rental charges, as you can see in front of you, between a physician and an entity that is below fair market value for a lease of space, and vice versa. Next slide, please. There are other waived prohibitions. We all have faced issues where we need a signature on a document. That has been part of the Achilles heel of the Stark Law, this strict requirement for signatures during this period of national emergency. Signatures do not need to be obtained immediately. We also know that group practice physicians have not been allowed to refer for services that are delivered in patients' homes. That has now been relaxed. It seems to make complete sense given the type of emergency we have, and we want to keep, and some people just simply don't want to go to a hospital, but are required to have services. Incidental benefits and non-monetary compensation. We don't have, the guidance does not give us a limit that exceeds the regulatory restrictions. $423 a year, for instance, for non-monetary compensation isn't that much. The guidance says we can pay more than that to our physicians in order to deal with the pandemic. Similarly with the medical staff incidental benefits. So you can be comfortable in knowing that if you pay more than that, you're going to be okay. Next slide, please. I want to just touch on loans. Loans between an entity and a physician have typically been well regulated, to say the least. In this era, though, there are certain physicians who are in trouble. They may need some loans to keep them afloat. They can enter into loans with an entity that are below market value, meaning that the terms are not necessarily available in a normal, commercially reasonable loan. The physicians can pay off these loans through the services provided. These services do not need to be COVID-19 specific. A physician can provide general services in the community that are required during the period of the national emergency, and those services can be deemed to be paid. It can be deemed to be paid loan payments. After the national emergency is over, of course, the loans would stop, but the physician could continue to pay them off through services or with some amount that has been established previously under the blanket waiver, whether it's fair market value or not. Next slide, please. Just want to touch briefly on physician recruitment. The guidance promulgated by CMS specifically reiterated that it doesn't permit extension of income guarantees to recruited physicians. The thought being that those physicians who have been recruited have already relocated and are already in the community practicing. However, the guidance does say that in order to keep those physicians afloat and to assist them, they can enter into reduced rent arrangements for physical space or the below market loans that I've referenced earlier. And next slide, please. Just have some closing thoughts. First of all, I know this has been a quick primer through the blanket waivers, but I want to reiterate that the volume or value of referrals requirement in the exceptions to the Stark Law continue to apply. You don't want to be in a position where your institution or your practice has secretly or otherwise paid for volume and value based referrals behind the use of a waiver. While you can get away with paying more than fair market value, you don't want to link that to the volume or value of referrals. I mentioned earlier the OIG guidance. That should give you some comfort. The OIG guidance does parallel the blanket waivers. So that's useful in making an analysis about a financial arrangement. Finally, I want to just say document. Even though the signature requirements are not required at the moment, you do want to ultimately get them. You do want to make memos of what you've done. You do want to create documents at some point along the line that will be signed or should be signed. You can rely on your emails to document what you've done and the arrangements you've done. And certainly even after they've been commenced, you should do this. So that said, look forward to your questions. I now want to pass this over to Jason Gregoire, who's going to provide you some other information. Thank you.
Thanks, Andrew. Hi, everybody. Jason Gregoire from Sheehan Finney. Thanks for joining. Just one quick note, there is a Q&A button if you go to the bottom of your Zoom screen. So feel free to submit any questions there. We'll take them at the end of the webinar. So I'm going to quickly go through some updates on privacy law and telehealth. As to privacy law, pretty much everybody in this webinar knows that HIPAA, the federal health privacy law, is what governs patient privacy of health information. OCR, which is the Office of Civil Rights, the federal health regulator, was ahead of the game, I think, relative to a lot of the federal agencies. They saw what was coming, and they came out in February, pretty much before I think a lot of us started to realize how serious this was, and said, remember, HIPAA still applies during the pandemic. So you can't just throw this law out and start making disclosures that you're not allowed to make. But don't freak out. Remember that there are existing exceptions to the HIPAA privacy and security rules that allow for disclosures to public health authorities, to family members and friends, and to others in a position to prevent serious imminent threat. And you don't need a written patient consent if you're using these exceptions. Next slide, please. So as many of you probably know, telehealth has kept a lot of practices afloat, and we'll talk a little bit later about the CMS relaxation and the state law relaxation of the previously draconian requirements and restrictive requirements for practicing telehealth. Suffice it to say that OCR said from a HIPAA perspective, we are not going to penalize anybody who's engaging in telehealth in good faith. While the security and privacy rules still apply, OCR pretty much opened the floodgates to allow providers to use apps like Skype and FaceTime, which are expressly not HIPAA compliant, and any other services that are, quote, non-public facing. So that was great in the sense of allowing providers to really jump in and be able to do privacy law, not have to go get business associate agreements with Google and Apple and Facebook and those kind of providers. Note, if you are a substance use disorder treatment provider, you always need to be thinking about 42 CFR Part 2, which I always call HIPAA on steroids, heightened privacy protection for substance use disorder treatment information. And it's important to note that this exception that they came out with and said we're not going to penalize for telehealth services, it's not just telehealth services related to treatment of COVID-19. It's all telehealth services provided during the national emergency. It's likely that this guidance will be retracted at the end of the emergency, but for now it's extremely helpful. Next slide. Briefly on Part 2, as I mentioned, if you're a substance use disorder treatment provider or a contractor to one, or you receive substance use treatment information from said providers, you always need to be thinking about Part 2, which is a general rule, pretty much requires you to get a written patient consent every single time you're going to disclose a patient's said information beyond the program. SAMHSA, the Substance Abuse and Mental Health Services Administration, came out with some guidance in March, which wasn't all that helpful, just kind of reminding providers that if you can't get the patient consent because they're incapacitated, you can make disclosures necessary to respond to a bona fide medical emergency, which is an undefined term. So if you're in a situation where you have a patient that's incapacitated due to COVID or due to substance use, and you need to disclose information like to a public health authority or to meet a medical emergency, you can do so. You have a broad discretion as a provider to make that call about when a medical emergency exists. Next slide. The CARES Act has overhauled Part 2 permanently, but those changes don't go into effect until March of 2021. Depending on your viewpoint, this is either really great or really bad, because there's been a significant effort afoot in Congress to try to overhaul Part 2, which has been in effect since 1975. It has always required patient consent for pretty much every disclosure, including disclosures for treatment, payment, and operations. The CARES Act has changed this. Now you're going to be able to have one-time patient written consent at the start of treatment for all future treatment, payment, and operations disclosures. While certainly the patient can revoke the consent, this is huge for substance use providers. This is the consent requirement has been the bane of their existence for 50 plus years. It really opens up the pathway to care coordination, population health, and presents far less administrative burden for said providers. Next slide. In addition, the CARES Act has incorporated a lot of the HIPAA terms and provisions right into Part 2, which many have called for years. So things like bringing in the breach notification requirements, requiring a notice of privacy practices, requiring an accounting of disclosures, including for TPO, and changing Part 2 from a criminal statute with criminal penalties and criminal enforcement by U.S. attorneys to it being a civil regime enforced by Office of Civil Rights. Next slide. So moving into telehealth now, we have about 4 minutes left, so a lot to cover. Telehealth, as you all know, there's been a lot of state law and federal law restrictions on providing telehealth, from CMS to state licensure requirements. Both New Hampshire and Massachusetts were proactive. In early March, came out with emergency orders that in both states effectively said all medical providers can perform telehealth services through all modes of telehealth, including video, telephone, apps, and more. All health insurance carriers, Medicaid and Mass, called Mass Health, and Medicaid managed care organizations need to allow in-network providers to deliver medically necessary services via telehealth. And, next slide, that mandates payment parity. So you have to pay the same rates for those services if they're provided by telehealth as if they were furnished in an office setting. These orders waived co-payments, deductibles, and co-insurance for telehealth services. They removed restrictions on so-called originating sites, i.e. where patients can receive services. So before the pandemic, patients couldn't receive services at home. They couldn't receive them at schools. Now they can receive them at home, school, SNF, hospital, federally qualified health center, and beyond. Next slide. Massachusetts, here's the order, but it's pretty much the same as New Hampshire. The only additional point in the Massachusetts order is health insurance carriers cannot require prior authorizations for telehealth. Next slide. Medicare. So Medicare is one of the biggest payers out there, as you all know, and Medicare came out with a blanket waiver of the telehealth, a lot of the telehealth requirements in the Social Security Act, which previously served as barriers. So before the pandemic, only physicians, PAs, and APRNs could provide telehealth, and Medicare would pay for them. Now they waived that limitation on eligible practitioners. That's opened the door for PTs, OTs, so physical therapists, occupational therapists, speech language pathologists, and others to provide telehealth. Remember to always think about your state licensure restrictions. If you're going to be practicing across the border, make sure that you've looked at those states' requirements. You may need to get an emergency license in that state, but suffice it to say, at least most of the time you'll be able to get paid for these services. Another major development for our federally qualified health center and rural health center clients, before the pandemic, they were not able to provide a telehealth. They were not an eligible distance site. Now they are. So effective March 6th, they've been able to provide services to patients at any site. Next slide. Audio-only telehealth is probably the biggest question or the most common question I've received. Can we provide services by telephone? Quickly, what you need to think about is there's a permissible code listing on the CMS website for telehealth. So if you just Google CMS telehealth codes, you'll find that it's a spreadsheet. You need to look through the spreadsheet and determine whether it says audio only. If it says audio only, you can do it and get paid for it. Pretty much it's audio only evaluation and management codes and behavioral health counseling codes. And CMS has increased reimbursement for phone only E&M. But remember, if it's not listed audio only, you do have to provide it via a two-way real-time video communication. Next slide. Putting the toothpaste back in the tube. Everybody's been asking, wow, we basically went light speed into telehealth when we had years of trying to fight for these changes. Are we going to be, is CMS really going to retract all this at the end of the day once the pandemic's over? Seema Verma, the CMS administrator, basically came out and said, you know, there's absolutely no going back. Well, there's probably going to be some retraction of some of the like interstate license changes. Be interested to see what happens with the others. Next slide. So just a few seconds here. This presentation will be on our website, but just a couple of quick other developments. EMTALA is the requirement in hospitals that, in hospitals that you must screen a patient who comes into the emergency room. CMS has allowed hospitals to screen at other locations. In New Hampshire, there was an order number 15, emergency order that authorized out-of-state medical providers to provide medically necessary services in New Hampshire if they get an emergency license and provide services through telehealth. Mass did something similar in that they did accelerated licensing for foreign educated physicians and are allowing nursing students and newly minted nursing graduates to practice. Next slide. Critical access hospitals, CMS has waived the 25 bed limit and max length stay of 96 hours. And finally, in both New Hampshire and Massachusetts, in New Hampshire, there was a immunity opinion that was issued by Attorney General Gordon MacDonald, which grants immunity to hospitals, nursing facilities, assisted living facilities, and other residential care facilities for services provided during the COVID-19 pandemic. Next slide. And Massachusetts actually put it into law, and it's a little bit broader in that it covers some non-residential facilities like community health centers and psych hospitals. But suffice it to say, healthcare professionals and health facilities are worried about liability. You know, a lot of the requirements are being relaxed. There's other, understaffing issues, very sick patients. They're worried about, folks suing after the pandemic is over. So sorry to have sprinted through that, but we wanted to cover a lot of these developments. This concludes the formal portion of our program. We are going to stick around and answer any questions that folks have. Remember that while the information we provided today provided some general guidance, it is not intended as, nor is it a substitute for legal guidance. And if you have any questions after the webinar, please feel free to reach out to Andrew Isles or myself. Our contact information is listed at the end of the webinar. So if anybody has any questions, feel free to submit them through the Q&A tab. Well, not seeing any questions again. We know we covered a lot in a fast amount of time. We thank you very much for attending our webinar today. Please reach out if you have any questions. We're here to help, and as you can tell, we have a broad. We've been helping clients on a broad variety of issues. Thank you so much, and have a wonderful day and stay healthy.
Jason, I think we've got a question.
Oh, okay, absolutely. So I guess it depends on this. So the question is, does the immunity apply to doctors working in ERs? And the terms of the New Hampshire Attorney General opinion are limited to residential care facilities. So I'm not sure that it would apply in New Hampshire. In Massachusetts, the order was a little bit broader. So there may be an argument that it applies there. But I think even with the New Hampshire order, there's some questions that arose out of it. And I think it seemed like there was at least an intent to try to apply it broadly. So time will tell. It looks like there's a follow-up question. The concern is pediatricians moving down to the ER, right? Yeah, no, it's a good question. And I think health organizations are concerned about, having practitioners who are not normally working in the, the emergency setting to be able to practice there. I think time will tell in terms of these immunity orders and legislation about whether they're going to apply or not. It's not exactly clear, at least from the New Hampshire order, whether it would apply in that circumstance. Andrew, you have anything to add there?
The only thing I would add is that the pandemic has created different types of intensity levels. Certainly a hospital that is under siege and dealing with a major surge, and we really haven't seen that much here in New Hampshire. Mm-hmm. But if that were to occur, and the hospital had to make some decisions about, for instance, using a CRNA in the ICU, who might normally not, who might only be work in anesthesia operations, that may be considered a prudent measure to use that individual in the ICU where they deal with intubation and those types of things. So I hate to say it, but it's kind of on a case-to-case basis.
Thank you for the question. And thanks again, everybody, for attending today. We really appreciate it. Have a great day and stay healthy.